Hello everyone, this is Cal Patel, CEO and co-founder of BrightInsight, continuing our Digital Health C-Suite series. Today I'm super excited to have as our guest Mark Bertolini, former CEO and chairman of Aetna, and currently on the board of Verizon and Mutual Mass Holdings. Mark, really a pleasure to have you on the show with us today.
Great to be here, Cal. Thanks.
Mark, normally we don't spend a lot of time on people's backgrounds, but you truly have a very remarkable one. So would love to hear your story, growing up in, blue collar Michigan to becoming, CEO of one of the largest insurance companies in the world.
I grew up in Detroit, son of a pattern maker, auto worker, and my mother was a part-time nurse. My mother wanted me to be a doctor. It didn't work out for me, but I did work as an emergency department coordinator, took care of some of the more severe people in the ER.
Tell me more about how your time, working in the emergency room in high school, how that shaped ultimately the leader that you became.
And my role, in addition to doing triage, was to actually interact with the families as they waited out in the emergency room. And those was everything from somebody with a bellyache to somebody who had died in a car accident or a gunshot wound or some other traumatic event. And it was very telling how mysterious the system was to the family, how difficult it was to explain to them what was happening and why, and actually spent time in a room with families praying for the person in the emergency room. And I found that there was a very tender part of the industry that was often overlooked. And I thought, wow, this is was the beginning of my learning about what is it about people's health that actually matters. And it wasn't that they had a disease or that they could die. We're all going to die. It was really, how can I live my life to the fullest based on whatever health status I have, which is what we ultimately came to at Aetna later in 2010, 2011.
That reminds me of one of the themes from your book that you talk about around doing the right thing versus doing things right, if I have that correct. Can you talk more about that, what you mean by that, and maybe give examples?
Well, insurance is a great example. We create rules because we give people really warranty cards when they sign up, and that when they break, they should go to the nearest dealership, which is a provider of some sort, to get fixed. And we put in co-pays and deductibles and out-of-pocket costs to make sure they think first before they decide whether or not they need to go. And the whole process really isn't about sitting down with the person and saying, what is it about your health that's getting in the way of the life you want to lead? And let's have that conversation first before we devise what's next. And so, I think the whole notion of this warranty card and rumbling around the system causes people in insurance to try to figure out the rules, sometimes circumvent the rules, and our employees are there to prevent people from breaking the rules. And there's no trust in that.
Let me use that as a segue to talk about maybe incentives more broadly and around the incentives in the healthcare U.S. system, right? And tying that to reimbursement and what really motivates the actions that the various players in the ecosystem take. Can you give us your take on incentives and reimbursement in the U.S. healthcare system?
My view is that our whole journey to value-based provider contracts is lost. I mean, we're wandering in the wilderness. If you've seen one value-based provider contract, you've seen one. They've got all sorts of flavors. A lot of them don't have enough meat in them to really change behavior. And because there are so many different payers, figuring out which patient belongs to which payer, which is going to drive my behavior, is, in my opinion, a wasted effort. The average American spends 20 hours a year in the healthcare system. That's 0.4% of their waking hours. That means 99.6% of the time they're in the world, in their zip code, doing all sorts of other things that impact their health far more dramatically than what the physician does when they see them or whatever provider sees them those 20 hours a year. Yet we have no view of that. And if the doctor has the time to ask, usually the response is some fraction of a lie. How's the exercise program going? 5 days a week, 30 minutes a day. How's the diet going? Oh, perfect. I had my doctor, my doctor who I used to call Doctor Don't Do That. He was trained in the UK. He said to me, you know, he finally brings in a glass of wine, an empty wine glass, and he goes, here's a crayon. I want you to draw on the side where you fill your glass of wine to, because you keep telling me you have 2 glasses of wine every night at dinner. I did it, and he goes, you know what, that's 5 glasses of wine. And that's why you're not losing weight. You're cheating. And so the usual problem is that we're out doing all sorts of other things that are far more impactful to our health. We now call them social determinants of health, than what happens when we're in with our physician. And so we have to build a system around that. And when we build a system around that that's actually engaging, then we're going to have a hope of influencing the rest of the system, because the price arbitrage between the medical industrial complex and what goes on in the community is so significant that if we could just keep people in their homes and in the community, we could reduce costs pretty dramatically.
Can you say more about that? I want to make sure folks really understand that point.
So if I were to go out on Amazon, and so Amazon did something last year that was, you know, it was in the paper for like a morning or an afternoon, but nobody really thought about it. They allow you to put your FSA and your HSA card on their payment site. Now, most people have no clue about what's in their FSA account or their HSA account. If you were to say to somebody, do you have one? They'd have to think. And then if you said, how much do you have in it? They had no idea. I have no idea. Yet what Amazon now does is when you buy something from Amazon that could hit that FSA or HSA card, they send you a note and say, would you like to use your HSA card for this? All of a sudden they've opened up a whole new wallet. Now, why is that valuable? Well, what you can buy on Amazon relative to what you'd have to pay in a durable medical equipment store or any other part of the current medical industrial complex would be far more expensive and far less convenient than if you do it with Amazon. So if you think about a world where we have a marketplace and a community, where we can create through a hybrid cloud that same sort of relationship with people in the community, the 99.6% of the time they're not with their doctor or their healthcare provider, and say to them, here's something that's repeatably convenient, always affordable, and delivered to your home, and you can do it on your laptop, I think people are going to jump on that. But they don't know what they need to do, how to order, what to order. When I came back from the ICU at Mount Sinai here in New York on March 22nd, I couldn't stand a whole time to take a shower. I was laying in an ICU bed for 9 days. So I needed a chair, and Mari, my wife, bought one on Amazon. Pretty cheap. So I think that kind of thinking in the community, what can we provide at home or in the community that doesn't rely on appointments, travel, inconvenience, hassle, insurance payments that we could do at home, I think would be a huge convenience and a huge relief for a lot of healthcare consumers. So I think that whole model needs to be rethought. I think what type of drugs people should be taking needs to be rethought. The opioid epidemic is a clear example of where we went too far, way too far with the use of opiates. And you know, it was that smiley face index. I can't never remember the name of the index. But if you had greater than 6, you got an opiate. I broke my left arm in 2015 and I went to the hospital. And I have no feeling in my left arm because it's disconnected from my spinal cord. And I go to the hospital and they immediately put an IV in to give me Dilaudid. I'm going, no, I have no pain. Got my discharge papers, 60 Dilaudid. I said, I don't need these. Well, we can't take it back. You'll have to just throw it away. So that sort of, you know, what kind of drugs people get, how we pay for them and price them, what's fair value are all important. And then I think the part that BrightInsight works on, which I think is really important, is what can we do with the data to make sure we're getting the right drugs?
You know, one of the common threads that I've heard from you through this conversation is this need to take a much more of a patient or consumer-centric approach to healthcare, whether you're the provider, the payer, the hospital, et cetera. And the same thing strikes me when we're talking about digital health, right? I see, talking to other digital health companies and CEOs, I see a lot of great innovation happening, but all typically in a siloed back end, where that innovation and the data and the insights coming from that will be limited to that company. Versus the patient-centric view you're talking about, which is when you have common infrastructure, you can now see the data from the eyes of the patient versus the eyes of the company, right? And so, as I think when you take a disease like diabetes, as you were talking about, for insulin-dependent diabetics, less than 5% of these patients get all their therapies from one company. Typically they're getting their long-acting from one company, short-acting from another, and so on. And so even with digital health innovation, unless those companies are operating on common infrastructure, you're never going to have a patient-centric view of what's really going on for that patient and their disease, because they're not really interested to know what their data is for one part of their therapy. They need to know what's going on with their holistic set of medications and diagnostics. Can you comment on that view and specifically how you were advocating for that at Aetna?
Right now, a lot of people who build these really cool apps and have all this innovative stuff that they can do with the phone or with the computer don't realize that unless it matters to me, I'm not going to use it. And if I got to go from app to app to app to app to app, I'm not going to use it. It's too hard. It's not worth it to me. It's not a great experience. And so this notion of saying, come to us and we'll connect it all for you with a high-tech, high-touch approach. We'll combine the two and you'll get as much high-touch as you need, and it's going to be about you, then I think people are going to get very engaged in what matters to them. The best example I can point to right now, which I think is absolutely amazing, is that so many physician practices thought that digital telehealth was a fool's errand. You're just trying to get me to work harder and do more by making me use a computer, which I don't want to use. I was talking to one practice in a Zoom call I was on. They went from 0 to 650 in a month, telehealth visits, and they love it. Action forcing event. It was now unsafe for patients to show up in your office. And I want to protect me and my family, so I'm going to use this. And guess what? It works. Oh my gosh. And so what's the engagement model? Well, only you engage people when it actually matters to them. And so that's why we, with some work we did with IDEO, came up with this model that said, my health matters to me. It's not about my disease state. It's about what it does to get in the way of the life I want to lead.
Mark, always a pleasure to speak with you. Really appreciate you taking the time and opening up your home and your time with us today, and look forward to connecting again in the near future. Please keep safe and enjoy the weekends up north in the warm weather.